beginning with us. So in our platform, he is really going to. Not going to leave him now. More, more and more.
We are live, please. We are live.
Yeah, very good evening, everyone, and a warm welcome to the installation of West Bengal chapter of ISMSICS. West Bengal, a land of Rabindranath Tagore, Swami Vivekananda, and also known for its high cultural heritage. And yes, also for the delicious cuisine like Mishti Doi, Rasgulla, and vibrant Durga Puja celebrations as well. So I would like to share my slides here. So is it visible?
Yes.
So we have our founder chairman, Dr. Amulya Sahu sir with us. So I request Dr. Sahu sir to say a few encouraging words for this webinar.
Thank you, Nita. And this is one of the last, chapter we are installing. And thanks to Sudipta, a bright young ophthalmologist, she could make it happen, and we are so happy. She brought the right people on the platform, and we are going to enjoy their company. And I thank you, Sudipta.
Thank you, sir. Thank you, sir, for the opportunity, sir, actually. Thank you for giving me the opportunity.
Yeah, because that shows your potential, and we are going to tap it again and again. Thank you so much.
Thank you.
And Nita, you are really rising in our estimation. Thank you so much, Nita, for organizing this.
Thank you, sir.
And welcome you all to this wonderful webinar. And two of my most, three of them, I have, Suhas and Harsul and Anga. All these people are very positive, creative, and wonderful people, and we would like to see them in our platform more and more. Thank you so much. Welcome you all.
Thank you, Sahu sir, for these motivating words. Now we have with us Executive Chairman Dr. Boramani sir. Sir, I welcome and request you to say a few words.
Yeah, good evening and welcome all of you. Everyone knows about ISMSICS, so I'll not take much time. We had installed so many state chapters in India almost 2 to 3 years back, but somehow West Bengal was remaining in spite of being such a vibrant state. But now we have caught hold of Dr. ISMSICS and Dr. Sudipta Ghosh, and here onwards, I think it will be one of the vibrant state with lot of activities in ISMSICS. I wish them a good success. Thank you very much.
Thank you, sir.
Thank you, sir. We have Vice Chairman Dr. Parikshit Gopte. He'll be joining us shortly. President Dr. Parun Nayak, sir, I welcome and request you to say a few words.
Good evening, everyone. And thank you, Dr. Nita. I'm really so glad that this ISMSICS is spreading its wing, not only in India, but all over the world. So, and then rightly said that West Bengal, somehow or other, it was missed out earlier, but now it's never too late. And I'm sure, as Dr. Sahu said, that they will be doing a lot of activity and probably take lead in propagating this surgery. So I welcome the team of West Bengal to this ISMSICS. Thank you.
Thank you, sir. We have a Chief National Coordinator, Dr. Satanshu Mathur, sir. Welcome, sir. We have a Secretary of ISMSICS, Dr. Deepak Mishra. Welcome, and I request you to say a few words, Dr. Deepak Mishra.
Thank you, Dr. Nita. First of all, I welcome all the team of Dr. Sudipta Ghosh and Dr. Pradeep Da to this ISMICS family. And as Sahu sir said, we have a lot of expectation from this new team and our new chapters. All the best and best wishes for you all.
Thank you so much.
Thank you, Deepak. We have a National Coordinator, Dr. Aarti Heda. Welcome, Dr. Aarti. Now, a little bit about the journey of ISMSICS. I request Into to play the video of this ISMSICS journey, which will show us how it is growing step by step nationally, not only nationally and also at the international levels, spreading the knowledge of cataracts and giving the excellent surgical tips.
Satansu is not there?
I'm not able to see him, sir.
Okay.
Scleral tunnel incision is a secure incision. There are newer advances in MSICS, like 2 mm SICS surgery, smart incision surgery, and customized incision cataract surgery. The International Society of Manual Small Incision Cataract Surgeons was launched in 2005 by Dr. Amulya Sahu, the founder chairman, and by Dr. Jagannath Boramani, the present executive chairman. Immediately after the formation, ISMSICS started organizing many international events. ISMSICS was invited to conduct a wet lab in APACRS in 2015. In 2018, in WOC, ISMSICS conducted a session and a wet lab. The Master's Guideline ebook was launched during this conference. In 2022, the ESO invited ISMSICS to conduct a 2-day workshop in Dubai. In the same year, the organization conducted a session in Ransko. In 2023, the annual conference of Emirates Society of Ophthalmology, ESO 2023, ISMSICS was given a session, a workshop, and a wet lab. In the same year, ISMSICS conducted a session and performed live surgery in Moscow. In ESO 2024 again, ISMSICS conducted a session, a workshop, and a wet lab. APAO 2024 offered 2 wet labs to ISMSICS. In November 2024, ISMSICS was invited to conduct a 5-hour symposium and wet lab by the European Society of International Ophthalmology. In India, ISMSICS has regularly been invited to various CPD programs, state conferences, and to participate in AIOC, the largest conference in India. ISMSICS started holding world conferences every 2 years, from 2015 onwards. CCC stands for Comprehensive Cataract Conference. Our past partners for these conferences were Aravind Eye Care System, Disha Eye Institutes, PGI Chandigarh, and LV Prasad Eye Institute. And in 2024, ISMSICS conducted the first zonal conference in Geo World Convention Center, Mumbai. In 2017, ISMSICS became a partner of Help Me See for training on simulator. ISMSICS has chapters in almost all states of India and in 24 countries across the globe. These are few images of online, as well as physical launching of chapters in various countries. ISMSICS has conducted more than 80 online webinars. The organization has a women's wing also. The online Global SICS training program was inaugurated in 2022. Though ISMSICS had published many journals in the past, from 2021 onwards, it started regularly publishing the peer-reviewed journal, which has been now indexed, with Embase and Mcare. This is our website. Scan this QR code to become a life member.
Yeah, thanks. That was an excellent video of a journey. So I'll reshare my slides. So now coming to the installation ceremony of West Bengal chapter. First, we have Dr. Asim Kumar Sil, who is the chairman. Chairman of, just a minute. Can you see my slides?
Yes.
Okay.
Yes. Yes.
Yeah, we have a Dr. Asim Kumar Sil, who is the chairman of West Bengal chapter of ISMSICS. He is a consultant ophthalmologist at Netra Niramay Niketan, Vivekananda Mission Ashram, Chaitanyapur, and also consultant director of ophthalmology, research and education at Siliguri Greater Lions Eye Hospital. He is a recipient of many awards. To state a few, he has received a CS Reshmi Award by AIOS, Dr. R.K. Das Award, and Dr. Srimati Satyarani Hazra Award by Ophthalmic Society of West Bengal. He also received Professor M.A. Martin Indo-Bangladesh Friendship Award by ICON, Dr. G. Venkatasamy Oration Award from Tamil Nadu Ophthalmic Association, Professor T.P. Lahane Award from Maharashtra Ophthalmic Society, and Outstanding Teacher Award confirmed by ISMSICS. I request our chairman, Dr. Sahu sir, to install Dr. Asim as the chairman of West Bengal chapter of ISMSICS. Dr. Sahu.
I welcome you, Dr. Sil. And your chairman, under your chairmanship, I want this chapter to.
Yeah, thank you, sir. Dr. Asim, you are there. You can say a few words. We present with the medal and the bouquet.
I am very much humbled to get the recognition from you, especially from Dr. Amulya Sahu sir.
Thank you.
He is our mentor in many ways, and I will try to do justice to the responsibility that you have given me. And SICS should go to higher and higher level, and the world should come to India to learn SICS. That's my wish. Thank you very much.
And that is why
Thank
we
you so
started
much,
the
sir.
World Conference. The one idea was there, we have always followed the West and particularly America. But once we do the World Conference, then they will follow us. And that is why we started the World Conference. They should come to learn from us. So, and all of you are masters in your field. I hope everybody join together to take this message to the world. Thank you.
Thank you, sir.
Thank you. We move to the next Dr. Pradeep Kumar Mohanta, who will be installed as the president of West Bengal chapter of ISMSICS. He's done his ophthalmology from PGI Chandigarh. He is a Vitreoretina fellow from Shankara Nethralaya, Chennai. Is a member scientific committee of AIOS. He's a founder of Netrajyoti Eye Hospital at Ranaghat, West Bengal. He's also founder of Tapoban Blind Boys Rehabilitation Center at Anulia. He has done multiple live cataract surgery demonstration at national and international conferences, and he's uploaded more than 2,000 cataract surgery videos on YouTube. I request President Dr. Barun Nayak to induct Dr. Pradeep Kumar as the President of West Bengal chapter.
Yeah, welcome, Dr. ISMSICS, and as a President of West Bengal chapter of ISMSICS, and I'm
So
sure.
Dr. Pradeep Kumar Mohanta, sir, as President.
Oh, sorry, Pradeep Kumar Mohanta. Yes, sorry. So, yes, I'm really extremely sorry. So, welcome you as President of ISMSICS West Bengal chapter. And I know under your guidance and under your leadership, it will flourish. Thank you. And I declare you as installed President of West Bengal chapter of ISMSICS.
And we'll present him with a medal and bouquet. Dr. Pradeep Kumar, would you like to say something?
Hello, am I audible?
Yes,
sir.
Yes, I'm very much humbled, and I don't know how much I can do for this role, but I'll try my best. And I always love to teach SICS to my fellows and those who come to me from many places to learn SICS and FECO. I'll try my best to do justice to this position. Thank you very much for having me here.
Thank you, sir, and congratulations. So moving to our next installation, we have Dr. Debashish Das. We have a Dr. Debashish Das. He is Honorary General Secretary from Eastern India Ophthalmic Congress. He is immediate past Honorary Secretary of Ophthalmic Society of West Bengal. He's done his DNB and VR Fellowship. He is presently consultant of Eye Foundation and Research Center. And he's organizing secretary of many conferences Ophthalmic Society of West Bengal. He has presented many papers in national and state conferences. He's also written a book on philosophy, radiances. That is very interesting. So I request Dr. Boramani sir to install Dr. Debashish Das.
Yeah, welcome Dr. Debashish Das, a very vibrant surgeon from West Bengal. I declare that Dr. Debashish Das is installed as Vice President of West Bengal chapter of ISMSICS. Thank you.
Dr. Debashish Das, would you like to say a few words here?
I thank all the dignitaries of the society to have installed me as the Vice President and have installed the West Bengal chapter. On behalf of ISOC as well as OSWB, I'd like to extend our full support and cooperation such that the society ISMSICS develops and it has a bright future in this state of West Bengal. With that, I thank you all once again.
Congratulations, sir. We present you the medal and the bouquet.
Thank you.
Next, we have a secretary, Dr. Sudipta Ghosh. She is an ophthalmic surgeon at NHRN Tagore, Kolkata, West Bengal. She is an ex-fellow as a clinical researcher and a senior resident at Royal Victorian Eye and Ear Hospital, Melbourne, Australia. She is ex-fellow glaucoma at Westmore Hospital, Sydney, Australia. Her main interests are cataract, glaucoma, medical retina, and pediatric ophthalmology. She is also state head of West Bengal chapter of Women Ophthalmic Society. She is a joint secretary of West Bengal chapter of ACOINT. She is managing executive member of Eastern ISOC, executive member of the Kolkata Association of Ophthalmologists, associated editor of JOSWB, and also reviewer of various national and international index journals. I request Dr. Suhas Hardipurkar sir to induct Sudipta Ghosh as the Secretary of West Bengal chapter of ISMSICS.
It's indeed a great honor for me, Dr. Sudipta. Your CV really reads very impressive, and I'm sure in your hands, in your very able hands, the West Bengal chapter is really going to do well, and all of us as the patrons of MSICS would be very, very happy to see SICS grow much more than what it is today. My best wishes to you, Sudipta.
Thank you so much, sir, for your kind words.
So congratulations, Dr. Sudipta. We present with the medal and the award. So next we have a scientific committee chairman, Dr. Kunal Banerjee. He has done his MS from AIMS, Vijayanagar, Karnataka. He's done his phacoemulsification and comprehensive fellowship from Mahavir Eye Hospital, Bangalore. He's done his glaucoma fellowship from Arvind Eye Hospital and medical retina fellowship from Arvind Eye Hospital, Coimbatore. Contact lens and ocular prosthesis training from Aligarh. He's an assistant professor in MGM Medical College and LSK Hospital, Kishanganj. He's senior consultant at Disha Hospital, Disha Eye Hospital at various places, Durgapur, Bardhaman, and Ansanol. So I request Dr. Deepak Mishra to induct Dr. Kunal as a scientific committee chairperson.
Welcome, Dr. Kunal. And here I declared and
Kushal.
Dr. Kushal. And here welcome you as a chairman scientific person for the West Bengal chapter. Thank you.
So thank you very much. Thank you all the respected dignitaries for having faith in me. And it's an honor to be part of this great society, and hopefully looking forward for a great procedures and great working ahead. And definitely we'll try our best to keep up to your expectations. Thank you very much, sir.
Thank you. Congratulations, Dr. Kushal. We present with the medal.
नीता, आपने सुदीप्ता का मुंह बंद कर दिया।
No.
Because I can
You
see
should
only.
have spoken something as secretary.
Yeah.
No, it's okay.
Yeah. Yes, Sudipta, bolo.
अब तो डॉक्टर सुदीप्ता नहीं बोलना है, पूरा वेस्ट बंगाल चैप्टर का रेस्पॉन्सिबिलिटी।
नहीं जी, please carry on.
Okay, sure.
Sunita Di has always been a soft-spoken and hard-working person, and all her work only does all the same.
सुदीप्ता ने शायद फोन पर बहुत सुना है, दिखता है।
We have the scientific committee members and executive members, Dr. Tathagatha De, Dr. Raka Chatterjee, Dr. Mrinmoy Das, Dr. Dipisha Chakraborty, Dr. Shauvik Dan, Dr. Dhrubajyoti Sarkar. So I request Dr. Ashok Nanda sir to induct all the scientific committee members for the West Bengal chapter of ISMSICS.
Thank you. I welcome all the 6 members to do a wonderful job. West Bengal, as always, is always vibrant, and I'm sure the society will do well and conduct many of these programs in their state.
Okay. Thank you, sir. I welcome all the scientific committee members and congratulate them with the medal.
We missed one member, Dr. Bidisha Roy.
Bidisha Roy, if you are there, most welcome, and welcome to the scientific committee members. So congratulations to all the members. So any of the scientific committee members or the secretary has to say something, please go ahead.
At the offset, I would really like to thank Dr. Santashu Mahathur sir for putting in the seed of ISMSICS into my head. And after that, I had a word with Dr. Amulya sir. And then after having the word with him, and then I was capable enough to, install the West Bengal chapter. And to my notice that a lot of our West Bengal colleagues were already a member of the ISMSICS. So we took all of them together, and we had few more new members to join in as members of ISMSICS. And that's how our West Bengal chapter got installed. And I would really like to thank Dr. Santasha and Dr. Amula sir to have the faith in me. Thank you so much.
Thank you.
Yeah, thanks. So now we have I would like to introduce today's moderator, Dr. Harshulta. Dr. Harshul, thanks for making your time here. We have a very dynamic and excellent eye surgeon, Dr. Harshul Tak. He's the director of Rawat Eye and Phaco Eye Surgery Center at Jaipur Laser Center. He's the honorary secretary of Rajasthan Ophthalmic Society and also executive member of IIRS India. He's a central zone representative of ISCKRS, and he's a national advisor of IJO. And everyone knows he's the founder and admin of the most loved Life Beyond Ophthalmology Facebook page. He's got many awards. He's a recipient of many awards. I'm just listing here a few. That is JCRS Rosen Award for Best Technical Article, that is sealing of a clear corneal incision with autologous blood. He coined the term hydroimplantation, and this technique was published in Journal of Cataract and Refractive Surgery and also in Cataract and Refractive Surgery Today Europe. TAC modified 25G visco cannula and 27G hydrodissection and hydrostitch cannula was released in IIRS 2024. And again, the one of the famous video challenging session, that is when the going gets tough, the tough gets going. It has completed its 36 episodes in various national and international conference. With this introduction, I welcome Harshul, and you can take over the scientific session now.
Thank you so much, Dr. Neeta, for that kind introduction. And at the outset, thanks to Dr. Amulya Sahu sir for making me a part of this wonderful society. And what started in 2005 as a very small society by Dr. Amulya sir and Dr. B.K. Naik, Dr. Boramani sir, we see now that it has grown leaps and bounds in these last decade. And I'd like to congratulate all the office bearers of West Bengal chapter. And I'm sure that under leadership of all the office bearers, the West Bengal chapter will do wonders in coming time. So today we have discussants for today's scientific program, Dr. Barun Naik sir and Dr. Ashok Nanda. And we have three prolific speakers. I'd like to introduce Dr. B.K. Naik, who is, we all know, is president of ISMSICS Society. He is past president of AIOS, and he was also past secretary of AIOS. We all know how much hard work he has done for AIOS. He is consultant ophthalmologist, head of department ophthalmology at Hinduja Hospital, Mumbai. He is also editor-in-chief of Global Journal of Cataract Surgery and Research in Ophthalmology. So we welcome Dr. B.K. Naik sir. And we have Dr. Ashok Nanda, another prolific surgeon from Odisha. He is postgraduate from MKCG Medical College, Behrampur, and he has done fellowship in comprehensive ophthalmology from LV Prasad Eye Institute. He is a medical director of Curve Vision Eye Hospital, Bhubaneswar, and also currently a professor at Department of Ophthalmology, High Tech Medical College. He is awarded with gold medal in ENT and ophthalmology in 1989. He's got many awards. He's got Best Paper Award in ISMICS Annual Conference in 2017. He is felicitated by IMA and Rotary Club for his outstanding work, and he has 29 publication in index journal and more than 50 publication written in various journals and health magazines. So we all know he is a prolific teacher also. We welcome Dr. Ashok Nanda. So I think,
Thank you.
And today we have three prolific speakers. We have Dr. Anaga Haru, Dr. Pradeep Mohanta, and Dr. Suhas Haldipurkar sir. So, first speaker for today evening program is Dr. Anaga Harur. We all know she is one of the most influential lady ophthalmologists in India, I would say today. She is member of ARC West Zone for All India Ophthalmological Society. This is the second term she is serving as member ARC. She is medical director at Anil Eye Hospital Private Limited, Dombivli since 1997. She is chairman of Gopal Krishna Charitable Trust. She is also vice president of Maharashtra Ophthalmological Society. She is ex-member scientific committee of Maharashtra Ophthalmological Society. She is executive member of IRSI. She is ex-coordinator of AIS newsletter. She is an amazing surgeon par excellence. So we welcome Dr. Anaga, and today she'll be speaking about challenging situations in phakic IOL implantation. We all know that today we have for last decade or two, we have options of correcting high myopia with phakic IOLs. But there are many challenging situations in which it becomes really tricky how to use these ICL and phakic lenses. So she'll be talking about those situations. Dr. Anaga, over to you.
Thank you so much, Dr. Harshal. Can I share my presentation?
Yes.
Yeah. And just let me know if it is seen.
Yeah, it's seen.
Yeah, we can see.
Just make it as a
Full screen, yeah.
Yeah. Is it seen now?
Yeah.
But make it, yeah, fine,
Yeah.
perfect. Please go ahead.
Yeah, thank you so much. At the outset, I'd like to thank the entire team of ISMSICS, Dr. Sahu sir, Dr. Baramani, Dr. Nayak sir, Dr. Neeta, and the entire team for having me here. And congratulations to the West Bengal chapter for the new team. So I would be speaking on challenging moments in phakic IOL surgeries, no financial interest. So the main reasons why we have a poor outcome in phakic IOLs is basically because of improper decision making. So either it could be improper patient selection, measurement, lens size, or implantation, which can cause an unhappy patient. So let's see a few preoperative, intraoperative, and postoperative scenarios. So in the preoperative workup, what is the most important parameter is the white to white measurement as well as the anterior chamber depth. So there are two basic ways. One is the manual measurement where we use the digital calipers, and the automated measurements where you can use various instruments like the OCT or the Pentacam or the IOL master, basically biometer, to get the white to white. So I usually feel that it is a combination of the two. Both the measurements need to be taken and you need to correlate well. So I usually take 3 values each of both, and whenever you're doing a manual measurement, you should do it yourself, so that you can have otherwise an examiner to examiner difference, and you compare the results. Also remember that the phakic IOL sizing is most important, and white to white and ACD are the most important factors. So for example, if you have 11.1 a white to white. So it depends on the anterior chamber depth. So if it's less than 3.5, then you will have a 12.1 size on the ICL. If it's more than 3.5, you'll have a 12.6 size on the ICL. So it's very important that you have the correct measurements of both the white to white as well as the anterior chamber depth. So now coming to a few examples. Now this was a 29-year-old female, a very high myopia, 8.5 in the right eye, and very high myopia in the left eye too, with a Paki which was less. So we did all the necessary tests, complete workup with the white to white, also UBM and digital calipers, and we went ahead with the surgery. So once the surgery was done, the size decided was 12.6 according to the nomogram. Second day post-op, vision was excellent, 6/6. IOP was normal, but the vault was low. So we all know that the vault normally should be around 500. So between say 250 to 700 or 750. But here the vault was a little low, but this was just a second day post-op. You can't really go on that. So we waited for around 2 weeks and then found that the vault was still low. It was still 178. Now we had a dilemma whether to change this and what to do about the other eye. Now the right eye, even we waited for 2 more weeks and the vault was still around 192. But because of the central hole nowadays, we can still wait and see and monitor these patients. So we went ahead with the other eye, but because the vault was low in the first eye, in spite of following the nomogram, we changed now the size to a bigger size, that is 13.2. So the next size. Next day, vision was good, but the vault was around 151. So we were now surprised how the vault was really low. But remember, the vault in the first few days could be low, probably because of use of pilocar and the possibility of viscoelastic material. So you need to wait and see. So by 21 days post-op, the vault increased to 397. So the message here is don't rush in to make any decisions in the first 1 week. Just wait for a few weeks to see what is happening and then take a decision. The second part is you need to know your lens, what exactly lens you are using and what are the landmarks. Now, for example, in the care group lens that we use, you have the leading left haptic which has this notch here and the trailing right side, whereas in the ICL you have the leading right haptic or the footplate which has the hole. So you need to be very careful when you're implanting these. So let's see a few surgical steps. Now here was an ICL being loaded and you can see here whenever you're loading or putting in the lens, so the left hand has to move back. But here when you see there was a slip, so the catch is here that your grip on the lens has to be excellent. Otherwise you can easily you can slip on the lens or it can tear. Now this was another situation where we are putting in the lens. This was an ICL. So when you're putting in, you have to be very, very gentle and very slow. Now here what happened was when the lens opened up, it opened up in a folded position and it remained there for a few seconds. So I tried to nudge the lens to see how it was opening up. So you have to be very careful to see. So now here you can see the hole in the right leading foot plate, which means it has opened up in the right way and you can continue the surgery. So the foot plates were all put underneath the iris and now we have done the stromal hydration and now going on to the next. Never attempt this. Now this was a surgeon who tried to put in the ICL and now you can see what's happening. It has opened up upside down. So look what he's trying to do. He's trying to flip the ICL within the anterior chamber, which could damage not only the corneal endothelium, but also the anterior lens capsule, causing a problem. So never attempt that. I myself had a situation like this. Now look what's happening. The lens is opening up and I'm waiting again. It has got folded. I'm trying to nudge it to see that it opens up in the right direction, but I'm not really flipping it. So after a few attempts, I just leave it to see how it's opening up. And you can see now, if you carefully look at the hole, you can see that the hole is on the left side. That means the lens has gone upside down. So you have to just remove the lens and then load it all over again. It can easily come out through the incision that you have made and you load it all over again gently through with the cartridge. And then the same procedure now we are doing. You just bring the lens into the cartridge and then you're implanting it all over again. This time it's implanting in the right way. So it's very important not to flip the lens in the anterior chamber. Now let's move on. If you look at the reasons why ICL explantation was done, in this chart you can see that the most common cause is improper sizing. Now, for example, now let's see this patient who has a high myopia and low pachy. Obviously, we went ahead with a phakic IOL. IOL master was done and, white to white was checked even with the UBM. and we went ahead with the surgery. So anterior chamber depth was good, 3.39, and both eyes YAG PI also was done. Remember, this was the one of the first IPCL, which was the second model, and this was one of the first lenses that was used. So I had already done a YAG PI. Now, post-operatively, you can see the eye was good, but vision also was good. But from the 11th day post-op, the eye pressure started increasing. And even with the maximum medical therapy, it wasn't coming down. But this started from the 11th day post-op. For till the 10th day, the pressures were normal. We saw the vault. Vault was around 375, which was fine on the second day. By the 13th day, vault had increased to 767. And by that time, we had already operated the other eye because this was the eye pressure started increasing from the 11th day. So by the first week, we did the other eye. Again, other eye, second day post-op, vision and IOP was normal, but from the fourth day, the eye pressure went on increasing. Vault was 768, increased to 849 by the 10th day. We also did a UBM to see whether it was placed properly, how are the angles. The angles were open. But look at this, the 15th day post-op, severe corneal edema, maximum medical therapy, not reducing. We did a gonioscopy on indentation, it was opening. And we put the patient on systemic as well as on topical anti-glaucoma medical therapy, but the pressures were not coming down. So we decided to explant the IPCL. So this was the patient on the day of the IPCL removal in the right eye, and in the left eye, it had also rotated. So this was a very difficult case. The patient was on topical, severe pain. You can see the congested eye, corneal edema, and pressures were very high. So we first, put in a 26 gauge needle to decompress so that there is no sudden hypotony. Went in, opened up the wound, slightly extended it, and now with the lens manipulator, I'm trying to bring out the trailing edge of the IPCL, which was close to the incision, bring it in front of the iris, and then very gently put in a lot of viscoat with sodium hyaluronate and chondroitin sulfate to protect the corneal endothelium, and gently hold the tip with the McPherson and then removed it. Once that was done, I even took a stitch so as to be careful, and then washed off the viscoelastic. The pressures came down and the vision was good post-op. This was another patient, 33-year-old, IPCL surgery done almost 10 years ago for a very high myopia. She came back with nuclear cataract. So remember, in while doing a biometry, because it's an optically clear medium, we don't need to make any changes. So this was a 1 diopter lens that we had to use. So the patient also opted for a flax procedure. Now, whenever we are using flax in presence of a phakic IOL, we need to make certain changes in the settings. Now, this was the surgery. Now, one dilemma here was this was again an IPCL, which is a little more rigid. So maybe I thought we would have to increase the incision to 3 millimeters and there could be a wound leak. So we decided to do a phaco underneath the phakic IOL first and then remove the IPCL after the phaco was done. So the IPCL is still in place. I just rotated it and then did the phaco. Here you can see how the capsulotomy has actually got torn. There's an anterior radial tear. It has been mentioned in literature that flax, whenever we are using with the phakic IOL, can cause anterior capsular tears because of probably glare from the lens. So after the phaco was done, the phakic IOL was removed, the irrigation aspiration of the cortex was done, and very carefully the chamber was maintained to prevent any tearing of the posterior capsule conversion to that, and the IOL was implanted. Post-operatively, vision was excellent. Patient did well. This was another patient who came to us with a very high myope and a cataract. And here the biometry was minus 3.5 and a very high cylinder. So we had an Ultima smart toric lens here. So because it was a high myope as well as a high cylinder, minus 3.5 lens. So here we are using the digital Varion overlay. And you can see how the cataract is seen. Again, we are just bringing in the putting in viscoelastic and both beneath as well as on top of the phakic IOL to protect the corneal endothelium. And this time we did not extend the incision. It comes out very well through a 2.8 with a hand-on-hand technique. So in the initial case also, remember now we have learned that there was no need to do the phaco underneath the phakic You can easily remove the phakic and then go ahead and do the phaco. So this was a very soft cataract. We just prolapsed it into the anterior chamber, phacoing it and doing the irrigation aspiration. But as we were removing the cortex, you can just watch onto the right side, there was a straight line. So I was wondering, so you can see here now, we are just stopping it. See that line, vertical line that you can see? So I thought maybe is it a ZD or something? But no, that was not. It was just a line, maybe probably because of the phakic IOL which was there for almost 10 years in the eye. So this was a customized smart toric IOL. Remember, again, you have to be very careful here to see that the hole is on the left leading foot plate. Now we are putting it inside the bag. It's a little bulky because it's a customized smart toric. So I'm literally putting it inside with both the instruments, and that line is still there. So I'm just checking whether there's any zonular dialysis or anything, but no. Here in the smart toric, the incision is also at 180 and the lens axis is also at 180. So this was the case, and post-operatively patient did extremely well. So to sum up, phakic IOLs are an excellent tool, but we need to do a detailed preoperative workup, use precise surgical techniques, and do close post-operative monitorings to get excellent results and happy patients. So thank you so much for your kind attention. And thank you once again for this opportunity.
Thank you.
Thank you. Thank you very much, Dr. Anaga, for that wonderful presentation. I think now most of the surgeons, they stop using pilocarpine whenever they are putting ICL, no? Because as you said, it does affect the sizing of the ICL, the vault of the ICL. So usually what you do bilateral simultaneous ICL implantation, or you wait for a day or two? What is your protocol
No, I
like?
never do bilateral simultaneous, and here are the reasons why. Because
Yes.
you're never 100% sure that the vault and the placing is going to be perfect. So I usually wait, check the vault, check the vision, check the IOP, and then do it maybe after 3,
Yeah.
4, 5 days at least.
Yes. So another important point is thorough wash of viscoelastic once you implanted ICL, because post-op IOP, spike, TARS, anything can happen. So you need to be very thorough in cleaning entire viscoelastic, and you need to spend 2 to 3 minutes just to take off the entire, if you are using HPMC. If many people, they use cohesive viscoelastic. Which viscoelastic you prefer, Dr. Anaga?
I prefer
For
HPMC.
ICL?
I prefer
HPMC, yeah,
HPMC.
Okay.
With high molecular weight viscoelastic, sometimes there could be IOP spikes. Here, even though you may need to spend a few minutes,
Yes.
I feel the
Yeah.
chances of IOP rise are slightly less.
Yeah, I think for beginners, initial it takes 4-6 implantation to get used to how the ICL opens, because ICL is a different material than IPCL or these kind of phakic lenses. So you need to be like well versed with how the ICL is opening. So one trick which I've learned over the years, which works, and it prevents flipping of the ICL, is always, whenever I'm implanting, I always take care of, I keep an eye on the 3 holes which are there in one line. No, so when you are injecting ICL, always take care. If your holes are going on this side, left side, you just rotate your wrist to right. So always try to keep those holes in a straight line. In that way, it will never flip. Otherwise, and see the Mickey Mouse sign. So when it's opening, so in that way, you will never have flipped ICL. And she rightly mentioned that if you have a situation like that ICL has flipped, never try to turn it in the anterior chamber. You can ICL easily comes out through 2.6, 2.8 incision, and you can again reload and again put the ICL.
And very interestingly, only the ICL is more prone to flipping. I've never had such.
Of course, because it's a soft
IPCL,
material,
because
it's
it's
a
a
different
more.
material polymer than the IPCL or the FAKIC by
Biotech and this
biotech.
is
Yes.
at a place like
Yeah.
that.
Anaga,
Dr. Boramani is asking something, I think.
Yeah, I want to ask Dr. Anaga. Now we are doing posterior chamber ICL implantation. So is periodic spectral microscopy should be done for these patients also?
Periodic.
Periodic spectral microscopy, maybe every year, something like that.
I have never done, and probably it's in the
It's
posterior
not
chamber,
needed,
so
yeah.
not required.
Okay.
Required.
Yeah, but the only thing is that when you do a ICL implantation, you must have at least 2,500 as the count. That's the minimum. Otherwise, it's not better to avoid. And the other question that I have for Dr. Anaga is that when the pressures were high, would it not have been a good idea to first make a couple of more PIs? Because many times you are not 100% sure
No,
that
sir.
it could be a component
The
of
PI was patent. It was very clear. And
was
here
patent.
I spoke, sorry?
The central hole was open, but the PI were also
The
there.
PI was patent, sir. PI was patent. PI was patent. There was no. So here I discussed this case because the vault was normal. There was no problem in sizing. If you saw, the vault was somewhere around 500, 600, 700. It was never very high. And it was not that the angles were closed also. I discussed this case with the company also. Probably there was some change in the water content because of which they had this problem. I did a UBM also post-operative because both the eyes had the same problem. And then, because of that change in the water content, there was some kind of problem in the angle, and that was causing the problem. And unfortunately, with anything, it was not reducing. So I had to explant it.
Dr. Barun Naik, you have to comment on anything on the high intraocular pressure?
No, I will just simply add to this that whatever she has done, a lovely presentation and brought out very important aspects of this surgery. That because from glaucoma point of view, the full workup should be done before any refractive procedure. Because that I always advise, because you don't know in future what you need. So at least you have the baseline readings for that particular patient in that regard. So this is what my comment would be. So I don't know whether Anaga is routinely doing this for all patients and keeping a record and handing over to the patient. That is the most important, because the patient may not come back to her after 10 years or 15 years. So goes to some other doctor, then at least they should know what was the readings, the baseline when the surgery was performed. And these days, I am sure PI is, because of the central hole, PI is not necessary.
Oh. Thank you, sir. Thank you for excellent comment. Thanks, Dr. Anaga, for excellent presentation. We'll move to our next presentation. I invite Dr. Pradeep Kumar Mohanta to speak on small pupil SICS using BHEX and nuclear cut or pre-chopper. Dr. Pradeep, you may share
Yes, am I audible?
Yes.
Yes.
Yes,
The
sir.
BX part is not today. It's difficult to cover two things.
Okay.
So I will speak on pre-chopper part in this today's.
Yeah.
Shall I share my screen?
Yes, sir.
Would have made a surgery with a BX, with a pre-chopper combined and told, you do so many.
Advanced.
What is interesting is to how to remove those pieces with the BX nails. It'll normally get, disengaged.
Share बोले. Is it visible? Hello?
Yes, sir.
Stop করবো. Okay, so this is an intumescent cataract, and in this case, I am We're going to do pre-chopper assisted SICS. To decrease the wound size, I'm going to use the pre-chopper. So this is the peritomy, size of the peritomy. The wound size is going to be about 4 millimeter. Mild wet field cautery is done, and this is the incision. A mild frown incision about 1.5 millimeter away from the limbus. And now the wound is constructed. Am I audible?
Yes, sir.
Yes. So this is the wound. Since I'm going to use the funnel need not be too long. Inside incision should not be very much wider than the outer incision. And air bubble is injected, and now this is the trypan blue dye is applied over the anterior capsule. Excess dye is washed out. I always do this. I always wash out the excess dye, and then I inject Visco to fill up the anterior chamber. And now I make first a 2.8 millimeter entry and use a utrata forceps to do a small rhexis first, a mini rhexis first. And now, after this, I use a 23G Simcoe cannula to decompress the capsular bag. This should be done thoroughly. We should give some quality. There should not be any elevation at any part to prevent rhexis run out. And now a small nick is made at the margin of the some more visco. The utrata is used again, and then we increase the size of the mini rhexis and do an optimum size rhexis of about 5.5 millimeter to 5.5 millimeter. And now comes the role of pre-chopper. The pre-chopper, we need a side port on the left side to introduce the nucleus manipulator, to also called nucleus sustainer. Here goes nucleus sustainer, and this is the pre-chopper. The nucleus sustainer hooks the opposite equator, and the pre-chopper engages just in front of the main wound in the nucleus substance. We come to the other side, rotate 180 degree, and divide the nucleus into two heminuclei. The two heminuclei are completely free, completely separated from each other. And now we use two Sinskey hooks and bring out one heminucleus out of the capsular bag. And now we have to deliver this heminucleus first. We can use a long, McPherson's that Dr. Anil Shah uses. In this case, I'm going to use a fish hook, enlarge the main, complete the main wound. Initial entry was 2.8 millimeter, and now the wound is open. And this is a fish hook, which I learned to make from Dr. Albert Hennig. And one heminucleus comes easily with fish hook, but the other heminucleus didn't come at on go. It broke at the wound. I just make another attempt and it comes. And then I use a Sinskey hook to bring this small piece that is still there. And then comes the role of Simcoe cannula. The Simcoe cannula is used to remove the small pieces, and the cortex also has to be removed. During cortex removal, we can use the stereocoaxial illumination. It gives better depth perception, and we can see the lens fibers very clearly all around. So cortical cleanup is done. And this side port is small, we cannot go through this. So we go through the other side port and use the main port to remove rest of the cortex. And now the anterior chamber is filled up with visco and a foldable intraocular lens is injected. The lens doesn't go in the capsular bag at onshot. So I use visco, use a Sinski hook and dial the haptics and place the haptics in the capsular bag. And the cortical wash is done. The purpose of pre-chopper is to decrease the size of the wound, and it's a very nice tool. Up to grade 3 or up to grade 3 plus, up to grade 4, we can use this pre-chopper, but in very hard cataracts, grade 5 or even harder, then in those cases, the lens nucleus may rotate. So in those cases, we should do a large incision, 7mm incision, and deliver the lens. Thank you very much. Hello?
Yeah. Thank you very much, sir, for that excellent presentation of a pre-chopper. Now I invite our discussion, Dr. Ashok, sir.
Yeah, that was very nice, Dr. Pradeep. My one concept comes to my mind is that the nucleus supporting device that you have, if it is a two-pronged device, then it can even support harder nucleus because it has a single supporting rod. It is probably causing problem. You cannot hold it properly. And if you can design something where it is two prongs rather than one, then it can probably hold better and you can chop harder cataracts. But anyway,
very good suggestion, Ashok. Very good suggestion. Yes.
So it has to be a spring-like thing which will go through a 2.2 or a smaller incision, and it should spring up and open up inside, something like that.
Right.
Okay. The other thing is because you are having a sickle cell nucleus chopping device, I do not know what is the tip of it. Is the tip blunt or sharp? Only the edge is sharp, or the tip is also sharp?
The tip is also sharp, but I have designed a straight one which doesn't have a sharp tip, that has a blunt tip.
Because the only problem is, by chance, if it slips and has a sharp tip, then you puncture the capsule.
Yes, yes.
That's the only risk I feel. But it's a good innovation and good thing. So, nucleus pre-chopping started by Akahoshi long time back, about 15 years back. And there have been so much of modifications now.
Yes.
Yes.
Any other questions for Dr. Pradeep?
So I had also one suggestion. Instead of dividing in two hemispheres, if you try to cut it in 3 parts, then probably the smaller incision also would be sufficient to
That is only possible if you can hold it properly.
Yes,
Here
no,
it's
your suggestion, Dr. Nanda, was really fantastic. That two prong will definitely make it firm. It will become more stable so that you can apply a force for chopping.
In snare, you can place it anywhere and pull it. But here, it has to balance. Both the forces, opposing forces, should balance each other. So putting it one side may not actually work out to make it 3 pieces.
Yes, yes.
Yeah, that was an excellent discussion. And now we move forward to our next topic, the most awaited. So I'd like to give the introduction of Dr. Suhas Hardipurkar. So I'll start sharing my slide. Sunil, can you share from your side because these slides are not moving?
I just open. Just
Yeah.
Neeta, whom would you like to introduce?
I would like to introduce Dr. Suhas Hardipurkar, who really does not need any introduction. He is
Yeah,
the
I know. Is it?
Pitamaha of cataract surgery. World knows him, but just as a formality, I would like
That is
to.
why I laughed, you know.
Yeah, yeah. That is a good question, sir.
Don't make him Pitamaha. Well, this is not good. He's a young man here.
No, sir, it's not by the age, it's by the knowledge and the excellence in surgery. Everyone has witnessed his surgery and everyone swears and learned. So many postgraduates and so many ophthalmologists are still learning by watching his surgery, sir. So I would like to introduce, though everyone, the world knows him, but just for the formality, he's a founder director of Lakshmi Ophthalmic Services Private Limited. He's a founder and chief trustee of Lakshmi Charitable Trust, which is accredited for DNB in ophthalmology. He has done pioneering work in spreading the phaco techniques in India way back in 90s. He is recipient of many awards and he is recipient of accredited certificate educator at APA CRS in 2018. He is recipient of CS Reshmi Award and State Vision Award by AIOS. He is a recipient of Lifetime Achievement Award from several societies in the country and very importantly recipient of Karma Yogi Pushkar and several honors from various state societies. He did more than 100 surgical demonstrations at various institutes of India and at the international level. He has trained so many phacosurgeons in the country and at the international level. And I think everyone knows the forceps for the rescue is the Halsey Rexis forceps. And he is a long-term phaco faculty at Winter Academy in Austria for 20 years. He was a past president of MOS, NROA, and organizing chairperson of last MOSCON, which held at Navi, Mumbai. He's an active Rotarian, nice to know, sir, and he's a past president and initiator of Global Grant for Eye Care twice in a row. So I am also a Rotarian. Nice to meet you, sir. And with a short introduction, I invite to share your presentation. We are all eager to hear from you.
Thank you so much.
Sir is my guru, and I am a phacosurgeon because of sir. Sir, you inspired me to be a phacosurgeon.
Many of us are, sir, like as I told, the guru.
Panvel is Kashi of ophthalmology.
So I'm really very grateful and thankful to the West Bengal chapter for calling me. So after these two real high-tech talks, let's come to very basics. That's converting to MSc-ICS. You should remember one thing. All of us, we do agree that phaco is a procedure that is universally accepted as an advanced and safe procedure for cataract surgery. And there are no two opinions on that, which doesn't really make SICS more, because SICS or MSICS is equally and maybe much better suited in special situations, because at times, even this is the preferred technique as a safer technique to avoid some complications. Like if I had to just run through some few indications, I would say if you have a patient with extremely shallow anterior chamber, especially when you have weak endothelial status in the presence of brunism cataracts, or when you have a compromised bag with incomplete rhexis, probably these are the cases where one should not be heroic to do phaco and mess up the case. Instead, one can safely do SICS and happily get excellent results. And we all have started like at least I had started with ECC, and then after that I was doing small incision cataract surgery, and then because at that time McIntyre, with those trisectors and bisectors, that's what I was doing. Then came phaco, and even after phaco came, I did continue to do small incision surgery for quite a while, and of course today also there are instances where I'm required to do as a primary technique and sometimes as a bailout technique. And here I'm going to show you 3 cases of bailout, which unless you have learned your small incision well, in such situations where phaco is going to be more damaging, you'll not be able to really easily come out of it. So I think every phaco surgeon also should be a good SICS surgeon. Now, I would go through this case. Now, this was extremely hard cataract with subluxation. And I thought, at least for the Rex's sake, I would do femto on him. And I did femto. Even with femto, the Rex's came out well, but the femto just couldn't penetrate into the nucleus because it was extremely bruising. And I was kind of prepared that I would put hooks and get this nucleus out. See, you should remember one thing. You have to be definitely sure that when the right time comes, you have to, there's no point in saying I would still continue with phaco, because here what's at your heart, is, his interest, his safety, his eye safety is always, very dear to you. So at this stage, this was the moment when I tried to make that chop, I realized that the entire bag was rotating. And then I thought, if I still continue to go with phaco, I will not be, I won't be able to excuse myself if I get into a problem. Now, this is a time where you don't have to change your axis. Wherever you are doing your phaco from, at the same place, you create a scleral tunnel. See, sometimes you have a tendency, might as well extend that corneal tunnel and get the nucleus out. But I don't think that's the right way, because you can very safely make a scleral tunnel little behind it. And here, when you're making it, astigmatism is not really your concern. Your concern is safely getting that nucleus out. And obviously, the bag is weak, the hooks are in place, but your purpose is somehow you go with your second instrument spatula and try to get the nucleus out of the bag. And once it is out of the bag, you can use any technique of your choice. And here I prefer to use Vectis and Sinsky, because in such situations I find it an easier technique to go about. My hooks are still in place, but I'm not too sure if so at this stage I realized that it didn't really make much sense in keeping the bag there. So I decided to go with a cutter and get the entire bag out. And then, of course, it depends on what you're comfortable with. I'm normally comfortable in such cases with an iris clip retrofixated, and it works good in my hands, and that's what I do. Now, this was a very interesting case. Obviously, the cortex had liquefied, and you could see it. The nucleus was hypermature. It was sinking in the capsular bag. So I was trying to be very gradual on this case, could finish the rexis. And then, especially in such cases, if you do not have your capsular bag stretched well out, what happens is the phaco, especially these nuclei, are very hard. So you're bound to use higher power and high vacuum. So I thought I would just put an endocapsular ring and stretch the bag so that that trampolining of the posterior capsule into your phaco tip can be avoided. See, if you notice, when the endocapsular ring is almost in, at this moment, it literally snaps in. but it didn't happen here. So that was the first clue that everything is not okay. That means either I had created a false passage by, while inserting my endocapsular ring. So I thought, let's take it out. And sometimes, if you're lucky, you can put it from the opposite side port and get it. And then I thought, why is the nucleus sinking? So I thought maybe I'll position it a bit and try some other way. But more I tried to position this nucleus back in the place, the nucleus started sinking. So here I changed the position, because for me to get a more ergonomic position or angle to get the nucleus out is that I shift 90 degrees away. Now here the eyeball is soft and I do not have enough time to create a scleral tunnel, because by the time I do it, the nucleus is going to sink further. Even then, the nucleus starts sinking, but your vectis literally comes to your rescue. And once the nucleus is brought out and made to sit on the capsular axis, then you have time to buy, because here the rexis is intact, PC is intact, it has just torn in the equator. Again, it's my technique of choice. I prefer it over visco expression. And then what I do is, since the rexis is intact, I put in a PMMA lens that goes and sits comfortably in the sulcus, and this case is completed. Then this was a case I had done recently. This I'm showing just to make, let some juniors understand that you have to get every clue. Now, even when I'm injecting viscoelastic, I realize that the entire bag is moving from one side to another. So I use a 26 number needle to make a sharp puncture there, complete the rexis, and now very tactfully and gently, I try to get, most of the loose cortex out. And now when I'm doing phaco, I know that the bag is moving. I'm not too sure. You saw that, this was the moment which literally shook me. Now, when I was trying to go, see, now this tells me that the bag, I knew that the bag was loose, but this particular action, told me that the extent to which the bag is loose is really remarkable. So I thought there's no point in continuing with. So I inject viscoelastic, stabilize the bag. This time from temporal, I come to 12 o'clock. And I decide to convert it. I use the scale blade to create the side pockets. Now the rexis is too small, so I go with the micro scissors and make 2 cuts on either side. Because in a small rexis, when you try to get the nucleus delivered outside, sometimes it causes more damage. The two-handed technique works good here. Get your nucleus lifted out of the bag. Nucleus is hard, although it's not very big. It's not very difficult to get this nucleus out. The only reason I showed all three with the same technique is that for junior doctors who are still not very well versed with the nucleus expression, mastering one technique is good enough, and they can always graduate into some other techniques. Here, when I try to get the cortex out, the cortex is stuck into the bag so firmly that that, this again shows me that, it's going to be difficult to get it. So, and in any case, since you're done, you cut your rexis into two and the bag is loose, the only obvious option for me was to just pull the bag. And when I try and pull it, there's hardly any resistance from all the sides. And the vitreous face is still intact. So at such times, you'll be very gentle, and at the first opportunity that you get, you will inject pilocarpine even before your cortex is taken out. So this is where I go with the pilocarpine. The reason for injecting pilocarpine is the pupil starts getting smaller. You have lesser chance of disturbing the vitreous. So the vitreous face is intact. And now with visco expression, the entire remnant of the capsular bag and the cortex comes out. And you don't have to do vitrectomy. And obviously, my choice here, and in most of such cases, is a retrofixated. And I believe that if done well, these retrofixated lenses are beautiful. I have a little different way of implanting it. Once it is positioned well and locked, I go with both the haptics together. Then I fill viscoelastic again and go with a very slender spatula. And through the same side port, both the enclavations are done. And of course, it is sutured. And these were some of the cases that I thought I would share with you in terms of, conversion. So if you have anything, I would certainly like to discuss with you.
Thank you very
Excellent, sir. Excellent surgeries.
Thank you, sir. Thank you very much.
Sir, I have one problem every time I have the literally subluxural cataract with mature, hypermature stage. I, like, as you said, I cannot sort of retain the bag. Bag invariably comes out even if you start off with SICS. Till the bags do come out with the manipulations. So that is something which I have not yet been possible for me in all hypermature cataracts with subluxation. Retaining the bag becomes a real tough job.
But have you tried that doing phaco and retain the bag? Because with phaco, you can always retain the bag and fix the bag. When you do SICS, at the last stage, when you're trying to get the nucleus out, that's when this little imbalance and some of the zonules tear off and the bag starts collapsing out. That's what happens.
When you have a 360-degree loose zonules, it's very difficult to even think of doing phaco. I'm really afraid of that. So in those cases, I normally go ahead and do SICS from the beginning. I try to make the bag is loose. So making a large rexis also is very, very difficult.
Yes.
So you tend to make a little smaller 5mm rexis, and through a 5mm rexis, it's usually not possible. You again are afraid to make cuts because you would like to retain the bag and put some fixators. If you have the rexis cut or extended, those will not work. So it's all bunch of difficulties in one case.
I can suggest you one thing. When you make let's say make a 5mm opening, and then on the two sides, if you can make little loops, meaning horizontally oval kind of a rexis, that's a secondary rexis. First, you made circular rexis, you've done cortical wash and all, you're still the nucleus is inside. Then you make a small cut on sides and convert it into a rexis. So that means it becomes.
Can I put a CTR, and then CTR will probably give more support to cut.
Of course, you have to. If you have subluxation, I think you have to put CTR, but you put a thread on that. So in case if you get it out, you always have thread to pull.
Okay. Yeah.
Yeah, of course.
Thank you.
Yeah, you have to do it.
Sir, when you are doing the temporal phaco and when you have to convert, I think is it the good way that if we continue on the same temporal or shift to the superior side?
No, it's like this. Now, like in that particular case, for me, the angle from where the nucleus could be taken out was definitely not from where I was doing my phaco, so I had to shift. But otherwise, there are people who do temporal SICS routinely. That means making a scleral tunnel temporal does really matter. In Arvind, they routinely do it.
Yes.
But the thing is, it's an unsightly kind of a thing. And that's the only reason you would come to 12 o'clock. But otherwise, let's say I've made a corneal tunnel at temporal, I would just shift back and make a scleral tunnel in the same axis temporally and convert to SICS.
We are cutting the cornea at two planes.
Or doesn't matter. At one plane, okay, the internal opening is two planes. Well, it doesn't really
But
matter.
that works, we have seen, even if you have done, but that the phaco entry that doesn't open up once you do a SICS.
No,
That
no, it doesn't.
That's it. The SICS plane is the default plane. So
Yes.
it goes behind the external wound opening of the phaco. So
Yes.
it really doesn't open up.
Yes.
But yes, internally you may have a single opening or you may have two openings, depending on whether you're able to come. The SSS internal wound exactly matches with the internal opening of the phaco wound.
But when you
I think
make
even
that
if
clear corneal extension, it's a very long kind of a cut on the cornea, and it's less stable than your scleral tunnel.
Yes.
Yes.
So basically, even if the scleral tunnel intersect with the previous phacocorneal tunnel, I don't think it matters.
Yeah.
Isn't it? And I want to ask you one question. In the second case, when the nucleus was about to sink, you avoided scleral tunnel and you had just for a faster action, you did a corneal tunnel or whatever it is. But before that, because you must be having a side port, could you have lifted the nucleus just by passing a repositor under the nucleus and kept it on the entry capsule?
No,
And then make a tunnel?
I tried that.
Sir,
Made an attempt, but it didn't work out.
Sir, normally what happened is because of the presence of vitreous, anything they are trying to put in, it pushes the along with the vitreous, it pushes the nucleus down further. Only posterior levitation is the only thing that can be done. You go pars plana and try to lift it up. Otherwise, anything from anterior side will have a phase of vitreous which will push the nucleus down.
But here what happened, when I took the 90 degrees away side for it, I had the exact angle to get my vectis down, kind of lift it. So I was lucky that.
Even then also you said yourself that when I was trying to push the vectis, nucleus was further going.
Further going.
You could hook it up. That's a different story. But it was still almost the edge of the nucleus was visible when the vectis was behind it.
Yes.
So in case of vitreous loss, is it mandatory to do vitrectomy, then insert the iris claw lens?
Of course. If you have vitreous loss, see what happens is you have to do vitrectomy, and plus you have to do vitrectomy under the iris at the site where the enclavation is done. You don't want vitreous to get entangled with your iris lenses. Yeah. So that's the reason if you can preserve the vitreous phase, it is better.
So while inserting your iris claw retro lens, then have you ever faced any vitreous loss, sir, while inserting the lens?
Meaning, if the vitreous phase has not been disturbed and then I put iris clip, and then no, it doesn't happen. It doesn't happen because vitreous phase will rupture if a sharp tip touches it or punctures it. Here, even when the lens is going behind, there's no sharp tip which can rupture the vitreous phase.
So good to meet you, sir. I'm meeting you for the first time.
Yeah. Thank you so much. Thank you. And my best wishes to you.
Thank you, sir.
On your shoulder now.
Thank you.
So one question, sir. One small question, sir. Hello. How do you clean the visco under the lens when you have put the iris claw lens?
Okay. What I do is, that's a good question. What I do is, I fill the visco on the iris, okay, all around the iris. Then I go and place my lens on the iris, and then I feel maybe viscoelastic on top of the lens. So that means behind the lens, I don't nearly put anything. See, because before you put your lens, you have to put visco. Now that visco, I try to put it all around on the iris, because if you put it in the pupil, it is bound to go down. If it goes down,
Okay.
there's no point in cleaning it. I mean, then you have to do vitrectomy to clean it up, and that means
Right.
it's a long job. But if there's a
Thank you, sir.
anywhere you have to do vitrectomy, then I would put a lens, go under the lens, and do vitrectomy and come out. If I
So in such cases, do you do pars plana vitrectomy all the time, or
I
you do?
pars plana if I have a PCR while doing phaco, and I have not been able to make PCCC, and there's a lot of cortex and vitreous is mixed, then I'll go pars plana. But otherwise, most of it you can do anteriorly because you pick it up very early. Let's say I have had a huge PCR and then I had to do IOL scaffolding. After I do IOL scaffolding and remove all the muck from anterior, then it's a chance and the lens is in place. Then I go pars plana and whatever is left behind, I clean it from there.
Sir, is there a role of PI in this when you enclave iris
No,
fixator
because
lens behind?
the lens has got a curve, so there's enough of a gap between the iris and the iris clip. So I never do and haven't done. Do you do, Pradeep?
No, sir. I don't do.
No iridectomy. No, I never do. I never do.
Which iris claw the company you are using, sir?
See, I've used most of them. Some of them have more of this curvature than the others, but presently I use Freedom and I find it sturdy and good with minimal vault.
Yeah.
If you want the exact very size design, then Care Group used to make it. But then one, it's very expensive. Number two, those claws are not as sturdy as very size. If you have ever used very size lens, which is an imported lens, their claws are very, very tough, which is not so with Care Group. But Freedom lens, I have no complaint. It's an excellent lens. Excel or Freedom.
Okay. Yes.
Okay, in that case, I think you have to see the curvature and then put it so that it is concave forward.
Obviously. Otherwise, if it's convex front, then you can't even, it will be mess. You can't do it.
So that I did not know. So I have used about 6 iris claw lenses that I have not checked. So I usually make a PI with a vitrectomy probe.
See, what you do is when you open that and check the lens, just lift the lens just vertically, and under the microscope you can see the curvature. If the vault is anterior, that's how you should put, meaning with anterior concave, put it on the iris, position is horizontally, clip it and try and go underneath. See here, if you notice, I use it with the right hand and hold with both the claws under the iris, and in the left hand I do.
Yes. Okay.
Any further questions for sir?
And
Is it better to confirm that the claw is open before inserting?
Oh yes. That is one thing that you have to do. But then, Ashok, you'll remember in my talk at Bhubaneswar, I showed, in that, those how iris. Do I have 2 minutes? I can show that because iris clip is something that, all of us. Can you
please
just
show, sir. Please, sir.
Can you
Please,
just-
sir.
Yeah.
I think IOCare lenses, the optic zone was small, and what I find in Freedom lenses, it is slightly bigger. The lenses are slightly bulkier in
Which
Freedom.
one? Which one?
Freedom, sir, Freedom. The claw is very good. It's very sturdy, but it's slightly bulky as compared to the IOCare. But now they have stopped producing the lenses.
Okay, can you see my screen?
Not.
No. Yeah. Can you?
Yes, sir. We can see.
Yes, sir. Yes, sir.
Now just watch it. You know, it's every cataract surgeon should use one extra step. Just see, I have positioned the lens, then I switch off the main light, and my fiber optic light is on. Now the main light is on. With the SIDS I position it. The pupil is constricted. I go underneath in one step. Then I switch it off, go with the oblique light, and see exactly, it's a clean job. You can see.
Oh, great.
And then you go to the next and just do it. That means you are doing it under vision, and it's so sleek. Yeah.
Oh, great.
So this is all
Excellent.
done on the side light.
This oblique light is from the microscope or the
No. Someone holds it in his hand. That's it.
Okay,
Bright
got
light holding.
That's from the vitrectomy probe,
Yes.
vitrectomy
And
machine,
the fiber optic light.
fiber optic light.
Yes. Got it. That was excellent, sir. That is very. Otherwise, this iris claw is a relatively blind procedure.
No, here it is not. See, that's the reason I want to show you.
Relatively blind otherwise, but with
Yeah.
this we can
Yes.
clearly see the enclavation and where we have to go at the plane exact. That
Yes.
was wonderful. Wonderful tip, sir.
Thank you.
So, you enclave both the haptics from with your left
One
hand?
port only. Yeah.
Yeah, with the
One port.
so in expert hand, I think they can do with the other, but usually the
No, if you use this technique with
Yes.
the side light, iris clip is one of the easiest and quickest and cleanest. See, you saw? You don't have to, it's not blind at all. You exactly indent it and then see where the claw is exactly in the middle and just, kind of press it a little, go further and do it again. And it's done in a zip.
So it's a vitrectomy probe light, sir?
Yeah.
fiber optic.
And your assistant should be trained to give the light in a particular angle so that you can see it better.
Great.
Thank you, sir. Nice tip.
Thank you so much, sir.
Very nice, sir.
Yeah. Now we are coming to the concluding of session. I would request the concluding remark by Dr. Barun Nayak, sir.
Yeah, thank
And,
you everyone, all the speakers and Dr. Suhas. It was really a spellbound, and it's nothing. Means I don't had any comment except that just to appreciate. It's a fantastic. So it's and lot of good points were brought in, and it was made very clear and with a reasoning. It's not that just that is my way. It is with a reasoning. So that's the beauty of it. So I really enjoyed this entire session and the installation ceremony of West Bengal chapter of ISMSICS, and I wish all the success in future for this branch of ISMSICS West Bengal chapter. Thank you once again, everyone, and good night.
Thank you.
Thank
Thank you so much, everyone.
Yeah,
I would like to thank my entire West Bengal team colleagues, Dr. Oshim Sil, Dr. Pradeep Mahanta, Dr. Debashish Das, Dr. Kushal, Dr. Tathagato, Dr. Raka, Dr. Minmoy, Dr. Shobik, Dr. Dipsa, and Dr. Bidisha for being a part of this West Bengal chapter. And I'm sure we will take it further and make a name as one of the best chapters in the International Society of Manual Small Incision Cataract Surgery. Thank you so much.
Great, Dr. Sudipta. So you are the secretary of West Bengal chapters, and we look forward to you. We have small announcement of East Zonal that also you can tell about. East Zonal Conference, which is there in Shillong on 15th and 16th. So we request everyone to be there. So
So 15th and 16th, we have the East Zone, Zonal Conference of ISMSICS. Expecting all of you to be there. We have a lot of good talks lined up. And invitation for faculty talk is also open. Registration for early bird is also open till 31st of January. And it is going to be held at Shillong Club. The weather is good. Ambience would be definitely well. And Dr. Jennifer Basoit, ma'am, is organizing the whole program along with her local team. And of course, we will be there and would love all of you to be there in Shillong for the East Zone Conference. Thank you so much.
Thanks, Dr. Sudipta, and best wishes for this East Zonal Conference. Now, the last vote of thanks. Before we conclude, I really would like to appreciate and give a heartful gratitude to our esteemed ISMSICS office bearers, our founder chairman, Dr. Sahu sir, our executive chairman, Dr. Boramani sir, and all the office bearers of ISMSICS. A big congratulations to the ISMSICS West Bengal chapter, and we really look forward to a great contribution from West Bengal chapter. And I also thank our discussant, Dr. Ashok Nanda sir, Dr. Barun Nayak sir, and main importantly, the excellent presentation by our speakers, Dr. Anaga Herur, Dr. Pradeep Mohanta sir, and everybody was swayed by and learned so many practical inputs, and also Dr. Suhas Hardipurkar sir. Thank you very much. And last but not the least, I thank the technical team of NTOD for the smooth execution of our event. And yes, to all the viewers, thank you so much. So thank you, everyone.
Happy Republic Day.
Happy
tomorrow.
Republic Day tomorrow.
Thank you everyone.